Hello.
Good morning. How are you?
I'm fine, thank you. Is this Ela?
Yes, I'm Ilya. Nice to meet you.
How are you, Ela?
I'm well. Nice to meet you. Hi, Don. How are you?
Terrific. Good morning, Ilya. Good morning, Falake.
Good morning, Lalon. How are you?
I'm just fine, thank you, except for it's not morning where you are.
Yeah, well, it's about afternoon now, really. Yeah.
Nice to see you.
Thank you very much. Yeah.
Nice to see you too, Ilya.
Nice to see you as well. I will say I've enabled screen sharing, so if you guys have slides and want to make sure they work, everything works with screen share, you're welcome to try.
Yeah, I'd
Okay.
like to try. Do you want to go
Okay.
first, Falake? You go first.
Okay, I will. Thank you.
Seems to be working fine.
Okay, thank you.
Of course.
Good. So I'll stop screen sharing now.
So did the test go okay, Falake?
Oh, I think you're muted.
Oh,
Yes, it was okay.
oh, good.
Thank you.
I just had, I just needed to step out for a minute. Morning, Krishan.
Good morning. How are we?
Terrific, thank
Good.
you.
How are you?
I'm good, thank you. Nice to see you all in person.
Good morning, Christian.
Falake, lovely to see you again.
Thank you very much.
Thanks for agreeing to be part of this.
Yeah.
Can you see a video there?
Yes, it seems to be working pretty okay.
Okay. I don't think I have any sound on any of these, so let me just, no, I don't have any sound. So sound's not going to be a problem.
Okay.
Okay, I'll stop sharing. I think I'm good. If you could see that video, I'm good.
Great. And is it Ilya?
Yes, Ilya.
Hi. Nice to see you after all the emails. Thank you so
It's nice to
much.
meet you.
I think Nick Jagodinsky will be joining us,
Oh,
but he didn't think he would be originally, which is why he pre-recorded his talk.
yes.
I think if we can just check that his recording works, we may as well just use that to start with, and then he's around for questions, etc. afterwards.
Sure. I saved it just in case that he didn't want to give it live. So here it is. Are you able to see it?
Yeah, should we just run it to see, check the audio works and that the picture looks okay?
Hey, good morning, Egeman.
Good morning,
Morning.
Don, everyone. Nice to see you.
Good morning.
Good morning.
And then was anyone able to hear the audio from the video?
I can't hear anything at the moment.
Oh, it's
No,
paused.
I'm
We're
not sure
not-
it's playing because his face isn't moving either.
Yeah,
Okay, now it's playing.
the video's playing, but we're not hearing any audio.
Okay. Let me see.
Were you hearing audio before, Ilya?
Yes, I can hear it on my screen, but if you're not hearing it, I'm not sure.
It's kind of weird that you can hear it and we can't.
Let me see. Okay. I'm gonna try again. Let's see.
It can all be done in the emergency department or when your factory coming
Yep,
up.
we can hear it now.
You can hear it fine
That's
now?
good.
Some graphs and not.
Okay.
Yep.
Is it
What did-
too
What did you
soft?
do? How did you fix it?
I don't know. I literally Googled Zoom sharing not having audio, and it said try these options. So I
raise
changed a few things quickly.
Ear surgeons, ear, nose, and throat who also use local adrenaline.
Sounds good. The
And-
volume's similar to listening to all of you speak. So yeah, that
Okay,
sounds good.
Good.
And it sounds just like Nick Yagodzinski, so we're good,
That's a good thing.
just like him.
And we get the real thing as well. So yes, very fortunate.
And if
So
anyone else has any slides,
I'm very excited because I'm going to see Egemen tomorrow in Turkey.
wow.
Me too.
Yeah, it's gonna be great. I'm really looking forward to it.
Yes, it's a great honor to host you, Don. And we are really I am thrilled, and we are all excited for you.
Yeah.
Thanks for coming again. Thanks for honoring us.
No, it's gonna be good. I've put a lot of time into the talks and there's a lot of new material, so it should be good.
Thank you. Thank you again.
Yeah.
And may I ask a question?
Mm-hmm.
How many minutes do I have or do for every speakers?
Let me check to be sure.
I think they said 8 to 10 minutes.
I think 8 to 10 minutes is generally the what we'd expect. Yes.
Okay.
Hmm.
And it's a bit longer for me. My presentation might then I need to shorten it. Okay. I will remove some of the slides. Thank you. I thought that it might be 15 minutes, then that's why it was around 30 slides, but I will remove some of them. Thank you.
And if you want to share your slides, make sure everything works too, you're welcome to.
Okay. It will be great. So
Ilya, in the PowerPoint that you sent us for the opening with the headshots, etc.
Mm-hmm.
There's I think my name was misspelt.
Was it?
Yes. Would you mind just because I'm assuming that will run from your computer.
Yes. Sorry, I believe autocorrect did that. Let me make sure.
do I have the permission to share my screen?
You should be able to share screen now too.
Okay, I will check again.
And then once you're done, I can share the headshot slide again and make sure everything's spelled correctly.
Thank you.
Okay. So this is the first Zoom meeting in my new laptop. And then that's why it says me that you should turn off your Zoom, and again you can't share your screen. So I will just turn off my Zoom, and then I will be back for settings to be done.
Okay.
Okay, thank you.
So I'll go ahead and share the accreditation and headshot slides then, to make sure everything looks correct. So I just added the accreditation overview slides first. So I'll go through these at the beginning of the webinar and then back into the headshot slides.
Okay. Oh, actually, it's spelled correctly there.
Oh, okay, good.
So yeah, that's fine. Yeah, that's, the only thing I think, just if you go back, all as the UK surgeons, we tend not to be MD. Is that a big deal? I don't think anyone's particularly precious about it, but yeah, we tend to be either MBBS or MBCH. Maybe just leave it as it is. I think we understand it's. Yeah, I don't know what everyone else's credentials will be, so unless you want to check it before we start, when
I see.
everyone
I mean,
gets
we can do that. I can change it to whatever you guys prefer, whatever's
So
best.
mine's MBCHB, so capital M, capital B,
You said
capital
MB.
C, small h, and a big B. Yeah. And oh, and I don't. There's no Leeds Hospital. If perhaps just put Leeds General Infirmary, I guess would be more accurate. Thank you.
Of course.
Hey everyone, how's everybody doing?
Doing well.
Great.
How are you?
How are you?
Great to
Hi.
see you all here, and
Hello.
bright early in the morning for some, and not so early for others. But excellent. I think I'll wait for Warren to join, and we can kind of go over kind of like the basics. But obviously, this will be led by your two moderators. I'm just gonna sort of just give some points of order and all that, and we'll go from there. I think we're waiting for. Oh, perfect. Speaking of the devil.
Yep.
Hi.
Yeah, and feel free, like Ilya's going through your slides, so if you want to make any changes right now, that's totally fine. Very easy to do, which is kind of why we do this in the beginning. Amber, hey, Warren.
Good
Morning.
morning.
Morning. Morning, Amber.
Hello.
Morning, Warren.
Morning.
Good morning.
Do we have all of our speakers? Let me take a look. We're missing. Let's see.
Eggman still hasn't tried his slides yet.
Yes.
Oh yeah, go for it.
He had to come out and go out and come back in, and Amber hasn't either. So
I'm sorry for this inconvenience.
problem.
That's okay.
For
don't
our
think-
colleagues, not from the US, are your degrees MD or are they MBBS? I think there's a little difference.
Yeah, I was just explaining that it varies a little bit. Some of us are MBBS, some of us are MBCHB. So
Okay.
I have
Tell
to
me
preface,
who's
I
what.
don't know what everyone else's is, so we'll have to double check it before we start.
That's
I
fine.
can see your slides, Eggman. You want to try a video?
Okay, thank you. Oh, okay. Sorry. Yes.
Yep, your video's working, my
Yep,
friend.
look
it
good.
looks good.
Yeah.
Okay. Thank you. Okay. Okay. So I'm closing my screen sharing and stopping it. Okay. Thank you. I'm sorry. But I had backup for in the other computer is ready for any inconvenience and it's open. But I wanted to try this one. Thank you. I think everything is okay.
Yeah. So just so I can update the slides as we go through these, Nick, what is your degree?
Sorry, what's my degree?
Is it MD? Is it MBBS? What?
MBCHB, FRCS,
Hold
dip
on.
and surge,
Hold on. MBCHB,
B, yeah,
FRCS.
FHEM.
Can you all see my slides okay? Are those working?
Amber, I can see your,
Yes.
if you got any
Yes.
videos, try those.
Okay, let's see. Let me slip ahead to that one.
Good morning, Nick.
Hi, Don, how are you, mate?
Terrific, man. Nice to see you.
Yeah, and you?
We even tried out your video. It works.
Oh, good, good.
If you don't want to give live. Amber,
The video's fine.
See your video.
It's working?
Yeah. Do you have sound videos?
No, no sound. I'll narrate for you all.
Oh, okay. Looks
Okay.
like a scary incision there, Amber. Holy smoke. You must be a surgeon.
What about, is it, I mean, I may butcher this, folate?
It's
Polake.
Polake.
Polake. What is
Yeah.
what are your titles?
MBCHB,
MBCHB, okay.
FWACS,
Okay.
and FMCS.
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 Yeah, okay.
Don't know if you can see mine there.
Warren, do you want to share the slides so they can see?
Yeah, I'm trying to still adjust them. What about Meg? What are your
Warren, nice to meet you.
Morning,
likewise,
Meg.
what are your credentials?
MBBS, FRCS, dip hand surge, which is the same as Nick, and then I just have to check the other one. I
Is
can't
it
remember what-
DIP?
No, so for dip hand surge, yeah, DIP, so capital D, and then hand with a capital H, and surge with a capital S. And then the other one is MFST, which is Mike Foxtrot Sierra Tango.
Okay. Hold on, I don't have quite the room in all the slides, but I'm going to make this work.
That's what I'm adding to.
Let's do this. And are you two doing it together? It was listed as you were.
Yeah, we are.
Okay.
So Falake is going to start, and she's going to control the PowerPoint, and then I'm going to come in when my slides start, and Falake is going to change the slides for me.
Okay, so let me almost have things.
While Warren's doing that, I'll just kind of go over some points for the webinar. So the webinar is going to be an hour and a half, and starting in about 7 minutes here. I don't want to say time because everybody's in a different time zone. And I'll introduce Warren and Christian. Christian, is it Mariathas or Mariathas?
Mariathas.
Mariathas. Okay, perfect. And then I'll introduce both Warren and Christian, and then they'll take it from there. And Warren, I'll just end at the very end, just introducing our next webinar we're doing next month with the ASRM. So just like the last 30 seconds of the webinar, we'll sort of go over that. But other than that, you and Christian will run the show.
Okay.
The other points I was going to make is if you're not speaking, you can blacken your video, and that way the audience can focus on the speakers. Other than that, when there's a discussion, feel free to open up your video and be visible during any question, answer, or group discussions. That's pretty much it.
Okay, and Gus, what is your title, your credentials?
I don't know if Gus is here at the moment. See,
No, I don't think Gus is on the call yet.
Anybody
He
know what his credentials are?
he's Professor Gus McGrowther.
General legend and all-round superstar.
Yeah.
There may not be enough
Um,
space for that.
I'd imagine that he's MBCHB because he's a Scots graduate. Let me just Google him and I shall find out for you.
Okay.
Um, so,
You see. See that now?
Yes.
yeah.
So here's the starting slide. Then I will go through, I'll introduce Don and Amber and Eggman. And then Krish will introduce our colleagues from the UK. And then at that point, we'll introduce everybody and then we'll start with Don for the first one. And then Don will start sharing.
Okay.
and are you wanting to share these slides, or
Warren.
do you want me to?
I'm sorry?
For the headshots, do you want to share the slides, or do you want me to? Because I added them to the accreditation slide, so I have them too. But
I got the titles on the thing you sent didn't have the titles and stuff like that. Do you have that updated?
I was adding them too, but either way works for me too. I
Okay.
know that one of the variations had Prashant's name misspelled, so make sure that's spelled correctly on that one too.
Let's see. Is this right?
So, Warren, my name's spelt incorrectly there.
Okay.
Mine as well.
Okay. How do you spell it?
Chrishan. Krishan.
Got it. And you go by
And
Chris?
my- Krish, most people call me.
Okay. And you're
Um,
not MD.
My credentials are wrong as well. It's
What are you?
MBCHB
Okay.
and then FRCS, all in capitals.
Okay.
And I'm also Dip Hand Surge as well.
What does that stand for?
It's the British Diploma in Hand Surgery. It's kind of our postgraduate hand qualification.
Warren, I've just put Gus's credentials in the chat for you.
Okay.
Finally found them. There's too many to read them out.
Yeah, no, that's perfect.
Also, Warren,
Yes.
just my institution's wrong as well.
Okay.
Sorry.
That's
It's-
good. What are you?
It's Leeds General Infirmary.
INFIRMARY.
Yeah, that sounds about right. Yep,
And that is the UK.
correct.
Okay, one moment, I'm gonna get.
I still don't think Gus is here yet. Does anyone have a good way of reaching him quickly, like his number or anything, to make sure?
Anybody can text him or call him.
It's we that has his contact details, but I'm guessing it's the middle of the night with we at the moment.
It's difficult to know where we is.
That's
I
true.
we has a family event in the middle of this that he was trying to get out of, but he didn't think he could. So I said we would hold things down.
I'll message we to ask him if he's
that's
got
a good idea.
Gus's details.
Great.
And then at the beginning, I will share the accreditation slides first. And once those are done, I will stop sharing, and then you're able to share the headshot slides and go through the introductions.
Ilya, does your accreditation slides include the slides of the moderator, or you're gonna put that up, Warren, right? You're gonna put up your own
Yeah.
slides. Okay, then I'll introduce you when you put that you and Krish's slide.
My name is misspelled as well, Dr. Amert.
Okay, sorry about all these. How
No,
do
no.
you spell yours?
I wrote the methods, but you can maybe just
Yeah,
take from.
okay.
I can spell as well.
No, I got it. EGEMENAYHAN. Okay, yeah, I was going on what was sent, so I'm glad we're doing this. So let me now run through this. Okay, everybody check yours as I go through this to make sure that nothing else is wrong here as a final shot. Done.
Okay.
WACS for mine. The Abikoye Folake. FWACS, please.
Okay, hold on. FWACS.
ACS, yes, please. Thank you.
Yeah, sorry about all these. Okay, how does that look?
It's okay, thank you. It's fine. Thanks.
And I will say it is 8:01. Are we looking to go ahead and let people in and go ahead and start?
I think you should.
Yeah.
I've heard nothing yet from regarding Gus,
Okay. Well,
but
we'll just
I think we're gonna have to get on with it. Yep.
yeah, we'll ad lib. We'll be good. Let's go
Okay.
ahead and blacken our screens here.
Oh.
Good morning. I'm Sonu Jain. I'd like to welcome you this morning, Saturday morning, to our global hand-in-hand series that the American Association for Hand Surgery has done with the British Society for Surgery of the Hand. We're going to be talking about fundamentals of hand surgery, where we are in resource-challenged countries in the 21st century. I'd like to introduce our moderators, Warren Hammert from Duke University and Christian Mariatas from Leeds General Infirmary. Warren?
Thank you, Sonu. On behalf of my co-moderator, I'd like to welcome everybody to this webinar. I think it's going to be an exciting 90 minutes, and we're going to have a lot of things that we can learn about taking care of patients throughout the world. And so I'm going to start and introduce the first portion of our faculty, and then I'll turn it over to my co-moderator. We're going to lead off with Dr. Don Lalonde. He's going to talk about wound care, a simple method to get the most wounds to heal, and some things that can be done that he is very excellent at describing this. We're going to have Dr. Amber Lees, who's going to talk about pediatric hand trauma, when to operate and when to observe, help us make the appropriate decision about pediatrics. Dr. Egemen Ayan is going to talk about tendon injuries, particularly flexor tendon injuries, and how to maximize success. I'll turn it over to Chris to introduce his colleagues.
So from the BSSH contingent, I'd like to welcome Nick Jagodinsky, who will be talking about Wallant and its use in fracture fixations. We will be having Folaki Abikoye, a plastic surgeon from Lagos, Nigeria, with interest in hand surgery, as well as Meg Burks, an orthopedic hand surgeon from Sheffield in the UK, talking about creative rehabilitation and virtual hand care. And we'll also have Professor Gus McGrowther, eminent plastic surgeon, formerly working in Manchester and more lately in Singapore, who will be giving us a talk on hand infections.
So with that, we're going to turn the show over to Dr. Lalonde, who is going to lead off and talk to us about wound management. Don? I think you might be muted, Don.
There we go. Sorry about that. I'd like to share with you simple ways to get wounds to heal. These are exposed dry finger bones that I helped solve a problem in Kumasi, Ghana. And this is classic. If you leave raw tissues open to the air, what happens? The tissues dry and die, especially the outer cortex of the phalanges. But the inner cortex is still alive. And if you stop the tissues from drying, you stop the tissues from crying because they're dying. And so when I met this patient, I got him to get in the shower every day and let clean water run over the open wound, then apply Vaseline and any clean, dry dressing to keep the Vaseline on. And I do this daily in Canada, and I've done it for 40 years, and it works very well. So they said, well, the shower water in Kumasi is not terribly clean. So I said, fine, pour bottled water over top after your shower because bottled water is plenty clean. And the best bandage for fingers is Coban. So Coban and Vaseline, which is available all over the planet, simply apply that and just don't let that raw bone cry and dry and die. And if you keep it greasy, granulation will come up through the outer cortex and eat that outer cortex of dead bone. And here's the patient 4 weeks later, and 5 months later, he went back to work. His biggest problem was stiffness. He was also totally stiff. And I've done this on dry skull at least 6 times in my career. This was dry skull that you could knock on. It was, the outer cortex was dry and dead. Classic, left it open and dry to the air. You can leave sutured wounds open to the air, but you can't leave raw tissues open to the air because they dry and cry and die. And here you see granulation tissue coming out of the outer cortex after a couple of months of Vaseline and a dry dressing. It takes a while in old people, but it works. This is a typical injury that I would see in our emergency department, but this was before we invented vac dressings. So we always wash them just with tap water and then apply Vaseline and dry bandages until it healed. And this one had an exposed metacarpal fracture. It had exposed tendons. And this patient never went to the operating room. He just healed with a daily shower, Vaseline, and bandages. All fingertips can be healed this way. This is a fingertip that's clearly over a centimeter. This man worked as a mechanic for 10 years in the winter in Canada. And the raw wound is covered by glabrous skin that's priceless. It contracts and brings with it nerves and blood vessels and glabrous skin over the tip. So when I see these, it's a no-brainer. They get Coban and Vaseline, the world's best finger bandage, This man never missed any work. He was back to work at 4 weeks, and here at 6 weeks, still did not miss any work. And so I would never do a Moberg flap on a thumb like this. You just imagine how it's going to look when it contracts, and you can see that that fat flap is going to cover the bone, so you don't need to shorten the bone in this case. Imagine the wound in time in 4 dimensions with wound contracture. If you don't think there's enough fat to close over the wound, then you can, or over the bone, then you can shorten the bone, but you can always shorten it later. This man went back to work at 6 weeks, no Moberg flap, and I guarantee you the result is just as good. It's a myth that you can't water fresh wounds. You should shower your wound every day naked. Let clean water run over it at the end. Take off the excess Vaseline goop with a Q-tip if you start to get an odor, because Vaseline doesn't come off in the shower, so it might start to smell after a week or two. Just take off the excess Vaseline with a Q-tip. And don't worry about skin maceration. People worry about that. Don't worry about that. You have a bath, you're fine with macerated skin. Whales live that way, and they're just fine. I also tell all my patients that red is raw, pink is healed. As long as it's red, you need Vaseline and a bandage. When it's pink and not oozing anymore, it's healed. Another thumb that healed at 6 weeks. So even if you had an amputation at the level of the middle phalanx, like you see up in the drawing up there, when I was a young surgeon, I was taught shorten the bone to the PIP joint so you can get primary closure. Today, I would never do that. The PIP joint is the brain of the hand. Don't create a brain injury. If you let it heal at the level of the middle phalanx, just like a fingertip, you're going to preserve the superficialis function, and you're going to preserve a superficialis finger. So even middle phalanx amputations, I let heal secondarily. Secondary healing is only a problem when it crosses a joint, and fingertips are not joints. And either is this a joint. This is a hand wound, especially in the palm. You can't stop the palm from healing. Well, you can slow it down if you let it dry and open to the air, but otherwise it heals quite nicely. This is a foot avulsion. I look at this like a giant fingertip, and the metatarsal heads are all exposed. I don't care. I don't care if bone's exposed. I was once taught you needed a flap for all these things. You don't. The mighty myofibroblast is my friend, and it brings fat and skin, glabrous skin, and nerves and blood vessels over those metatarsals. And that reconstruction fits in a shoe, unlike a free flap. And that reconstruction is not numb, unlike a free flap. So I would not have a free flap on my foot for this in 2024. I would have put a free flap on there in the 1980s, but not now. Even after this melanoma excision by our Mohs surgeon, 1 year after melanoma foot excision, it's not over a joint, and he did not get a significant contracture. You can see there might be just a little bit of pulling there, but he can walk beautifully. And I'll finish with this slide. This is an infected pretibial hematoma, and we do these the same as Nick Jagodzinski is going to show for long bone fractures. You blow up the skin all around so that you can debride this with Wallant. And after you blow up the skin all around, you blow up the periosteum of the tibia all around. So I used a total of 120 milliliters of 0.25% lidocaine with 1 in 400,000 epinephrine. And after I let it work for half an hour, I came back and debrided all of the dead tissue. And then we showed the patient how to clean the wound every day in the shower after I washed it out with iodine. I actually did this in an exam room with a headlight. we're gonna put Vaseline and a Coban bandage on there. So that's clean right now. All the old clot is out, all the dead tissue's out. So you need to stay off your foot. You don't drive anywhere. You sit in the back seat as a passenger with your leg up. Get off all painkillers and listen to your body. Just don't do stuff that hurts. Okay, if you're doing something that hurts, you're helping the germs. Just keep remembering that. And you don't know what hurts if you have painkillers in your ears. So no painkillers, don't do stuff that hurts. Keep your leg up. Keep taking the antibiotics. Shower every day. Take the bandage right off. And I'm gonna show you how to put a clean bandage on it. We use Vaseline instead of drains. Wow, that's great. Thank you. That's good. And then you just make sure that there's enough that the whole thing gets covered. You just don't want it to dry and die. And then you just put that on there, like that. Okay.
Basically, I think I take.
That's exactly what we're doing. Now, because I just drained it today, I'm gonna take a second gauze. Because, you know, some of that water might come out of there. Okay. But after your shower tomorrow, you just need one gauze. Okay. And these don't have to be sterile bandages. You can use panty liners, sanitary napkins, diapers. They just have to be clean. And the Coban is reusable. And if you Google Lalonde, Simple Care for Wounds, there are many videos and complete explanation of how to do this. Thank you so much.
Thank you, Don. That was amazing. Certainly gives us a lot of opportunities to take care of these types of complex wounds without fancy flaps and a lot of resources. So thank you. Next, I'd like to introduce Dr. Amber Lees. She's from California in the United States, and she's going to talk to us about management of pediatric hand trauma. Amber?
Thank you so much. It's a pleasure to be here. I appreciate the invitation. And let me get this started up here shortly. All right. I provided my contact information should anyone want to ask questions afterwards. I'm happy to chat with anybody. But I think it's nice if we start thinking about what type of injuries pediatric patients get. And this was a study out of South Korea looking at demographics of injury. And there are some trends to point out. The majority of hand injuries in toddlers and preschool children are secondary to crush injury. And that can be just related to the stage of development where they've started to explore their environment with their hands. And in this regard, toddlers tend to present with a predominance of injury in the central digits, which are longer and more susceptible to crush. We see a trend towards more sports-related injuries as children get older, but by and large, these are low-energy injuries sustained by children. And as I had mentioned, children are more likely to injure the fingertips the younger they are, with more proximal injuries seen more commonly in older patients. It is a pleasure to have followed Don Lalonde, who really laid out nicely the opportunities for secondary intent healing. And fingertip injuries do heal incredibly well with dressing changes, even when bone is exposed. And although they heal well in adults, as Dr. Lalonde showed you, they heal even better in children. And this is really likely due to the fact that children just have fewer comorbidities than adults, and that helps create a better milieu for rapid wound healing. And I will cite Dr. Lalonde's paper here. The only difference that I find for pediatric patients is that it is hard for parents to perform dressing changes for children because it is often painful for them. And it is, I think, emotionally challenging for them as well. And so for children, what I will do is after I've cleaned the wound, I will place that Vaseline and gauze dressing, and I will put a cast in place or some type of protective dressing, and I will leave that in place for 2 to 4 weeks. And after that time, it can be removed and the wound is healed underneath. And this is much less painful for the children because they don't have to go through the washing stage of things, and much less painful for the parents, and limits the number of resources that are required. Now, if the patient presents with a part that has been amputated, I think it's very reasonable to place this on. These don't always survive. This was a study that showed that very few of them, actually only about 13%, had complete survival. But the composite grafts did really well. The morbidity is low, patient satisfaction was high, and patients all achieved acceptable cosmetic and functional outcomes, probably because those that failed went on to secondary intent healing. And so this would be a clinical example of a child who sustained a long finger. Again, it's the central digits usually, tip amputation with exposed bone, composite graft placed in the emergency room, and here they are 9 months later, and you can't even tell which finger it was. I will just point out that it was this one. And so these tend to do quite well, either by, the graft surviving or by secondary intent healing. Now, when we have children presenting with nail bed injuries and subungual hematomas, there is a historic teaching that the nail bed needed to be removed and then, the nail plate removed and the nail bed repaired if the hematoma was more than 25% of the nail surface. And I don't know that that's necessarily true. There have been a couple studies looking specifically at children. That's randomized 52 children who had larger subungual hematomas and an intact nail margin. They had a long-term follow-up for this patient group, and they either gave them an operative intervention or trephination alone. And the operative group did have 3 transient nail abnormalities, and the cost was substantially higher than trephination alone, but there was no difference in outcomes otherwise. And a very similar outcome obtained in this study, where they offered 3 treatment arms, including no intervention at all, and the only difference they found was cost. And so I think it's reasonable to offer trephination for pain control if the patient comes in at a reasonable time, but it is not necessary to remove the nail for these patients if the nail margin is intact. If the nail margin is not intact, you're often going to see a displaced fracture in this situation. These are patients that do need an intervention, although it isn't necessarily a full operative intervention. These can be easily performed in a clinic or emergency room setting with a limited number of supplies. And I usually tend to approach these in a very self-sustained fashion by, taping my local anesthetic to a reachable place so I can take care of everything myself. Although this is an adult patient modeling for me, simple cleaning of the wound with a limited number of resources involved. And I tell patients that we can boil a cup of salt in a gallon of water and make normal saline. And that can be a great alternative if clean tap water is not available. Limited number of sterile supplies required. And although I love a tourniquet available to us in the US, these aren't always available. And simple extra supplies will suffice for a finger tourniquet for children. Classically, these are repaired with fine chromic suture, but there is an option if surgical glue is available to use that as well. And this has been shown to have good outcomes in pediatric nail bed injuries. I always stent the nail fold afterwards, and I do this with a simple figure of 8 suture. I find that this is better than trying to drive a stitch right through the nail bed that I tried to repair and disrupting the repair. And the figure of 8 has a tendency to kind of pull the pulp dorsally, which often helps with fracture reduction, and that alone will be sufficient for getting the bones in the alignment for healing. And then I provide a simple dressing for the patients, and I usually do soft dressings that wrap around the wrist so it's harder for them to fall off the fingers. I try to avoid Coban in children and other potentially tight dressings because it's sometimes hard for parents to tell if the child is crying in pain because of the injury or crying in pain because the dressing is too tight. And every year I see a consultation for a child who's lost a fingertip from an over-tight bandage. So I am very cautious with those. In the pediatric patient population, fractures tend to occur through the physis because it is unmineralized and weaker than the surrounding bone and ligaments. However, the majority of these can be treated non-surgically due to that remarkable power of the physis to remodel. In general, if they do need a surgical intervention, that's really just a closed reduction and percutaneous pinning, and we always try for just reduction and casting alone at first. But with that thick periosteum and high remodeling potential that makes the pediatric patient so unique, rarely ever do we need rigid internal fixation for these patients, although you'll hear more about that from Dr. Jadoginsky a little bit later for some other patient populations. And we're, I think, all familiar with the power of an open physis to take a very displaced and band-aided fracture over a very short period of time, weeks, to improved alignment, which will continue to correct as the child grows. Now, there are some exceptions to this non-operative rule, and that is for unstable and open fractures. So those that have failed a closed reduction or are open in some other way. One of the critical ones not to miss is the Seymour fracture, which is a Salter-Harris 1 or 2 fracture of the distal phalanx physis and has avulsion of the proximal edge of the nail fold, and that has interposed itself in the fracture site. These cannot be closed reduced because of that interposed soft tissue and do require a procedure. And again, that doesn't necessarily have to be performed in an operating room, but you have to get that soft tissue out and reduce the fracture and repair the nail bed. Clinically, these sometimes mimic or can be mistaken for mallet fractures, and it is an error to try and treat these with a mallet splint. They do require an open treatment. Another one to watch out for would be a bony UCL injury in children or something where there's a critical ligament that needs to be reattached. And then the limitations of the open physis is that it can correct in-plane angular deformity, but it cannot correct rotational deformity. And so a diligent assessment of the rotational profile of any injured finger is really important to avoid this difficult deformity. So this is a patient with clear deformity of the small finger with a rotational malalignment, failed closed reduction. And so a simple percutaneous pinning is appropriate for this patient. Tendon injury, which you'll hear a little bit more from Dr. Ayan shortly, in children requires surgery just as it does for adults. However, in contrast to adults, where we encourage early active motion after tendon repair, children need to be statically immobilized with a splinter cast. And the advantage of this is that it doesn't rely on the patient's cooperation as the dynamic splinting would do. It is also a less resource intensive protocol because you don't need an occupational therapist, you don't need custom splinting, and you don't need that guided care. There have been a lot of studies that have looked at complications in the management of pediatric tendon repair, and the primary complication is rupture associated with early motion at the repair site. And so I cast these children in an appropriate position for 6 weeks without compromise, and that includes no tendon adhesions and no joint contracture, and usually just provided toys after cast removal, they will therapize themselves. Burn injuries are common in the pediatric population. They are the 5th most common cause of non-fatal injuries in children. An injury to the hands and digits represents about 35 to 25% of burns that children sustain. The management of thermal injuries in children is largely similar to adults and largely non-operative. These are usually treated with dressing changes, again, as Dr. Lalonde nicely laid out, and the average time to healing is about 10 days. Now, those that have not healed within 2 to 3 weeks can be taken for skin grafting or secondary debridements. Another indication to operate sooner would be a patient who has a need for a contracture release or significant flexor tendon exposure. I will point out that we do take care with splinting these children because we want to protect against contracture. And so these children may be splinted in a more extended position to allow for that healing without contracture. And then the last and most dreaded thing I want to talk about in terms of operative pediatric trauma presentations is compartment syndrome. We think about compartment syndrome being due to either 2 general causes, either decreased in compartment size or an increase in compartment volume. And I would just encourage you not to miss the children who have an increased volume issue. Crushing injuries are more common in children for reasons to have a compartment syndrome, and even children who have hemophilia with spontaneous bleeding into the compartments. Classically, we think of compartment syndrome as presenting with 5 Ps or maybe a 6th P. These are not necessarily very useful. The things I always tell my trainees is that they need to watch for those patients coming in with an intrinsic minus presentation, a tense and swollen forearm. They may not have pain because the pain is only present as long as the nerve is viable. And in children, we don't really have Ps so much as we have As. And these are children who are anxious, agitated, and have increasing needs for pain analgesia or pain relief. In children, the number 1 cause of compartment syndrome is going to be a supracondylar humerus fracture. And in a resource limited area, it's an overtight bandage or cast. And so these are the 2 things that we really need to watch out for. Those children coming in with a supracondylar humerus fracture, there have been some nice studies that laid out when they need an operative intervention early. And so looking at those that had displaced fractures and absent pulses with either perfused or not perfused hands, if the hand was well perfused, usually fracture reduction alone was sufficient treatment, even if the pulse was absent post-reduction. And in the poorly perfused hand, fracture reduction failed to improve that for the majority of cases. And those are the kids that are going to need vascular repair and be at high risk for developing compartment syndrome. And so that's the thing that I tell trainees to watch out for. And this would be a clinical example of a very significantly displaced supracondylar humerus fracture who did require vascular repair and compartment release, but with skin grafting maintains all of their motion, which is the critical long-term result. If you're worried about a bandage being too tight, a simple univalve will release most of the pressure, and you can release padding as well to get further release. I think in the interest of time, I will skip through the videos of our compartment release, but these are available as a video supplement in Green's Operative Hand Surgery, and I think on a number of websites. Don't neglect the hand as well. This is a video, again, associated with the same in Green's Operative Hand Surgery. But for children who sustain a lot of distal hand injuries, ensuring that we've released these compartments to protect their function is really important. What do we do with the open wound afterwards? Here in the US, where we have a multitude of resources and spend a lot on healthcare, the wound vac is commonly used. but a wet to dry dressing, a Vaseline gauze dressing, as Dr. Lalonde mentioned, retention sutures, any of these things can be employed well. And often in children, I will keep them in the hospital for a few days for dressing changes and do a primary delayed closure or skin graft afterwards, as I did for this young boy who sustained a treadmill injury. And with simple closure has preservation of his hand function. I am happy to take any questions at the end and look forward to turning this over to my colleagues to learn more about fracture fixation.
Thank you so much, Amber, for a very, very thorough talk on pediatric hand injuries. Before the next talk, just mainly for the audience, what we'll try and do is take any questions after Nick's talk. So if you have any, please put them on the chat and we'll get through them in the Q&A session. So without further ado, I'll introduce Nick Jagodinsky's talk on Wallant in the context of hand fractures.
Good afternoon. My name is Nick Jagodinsky. I'm a hand surgeon in North Devon in the UK. Thanks for asking me to talk at your global webinar on Wallant fracture fixations. So what is Wallant? It's wide awake, local anesthetic, no tourniquet, or as adrenaline is the key ingredient, you can swap the last A for adrenaline. It's where the patient and the limb are wide awake and you can test active intraoperative motion. Wallant juice, it's not a secret potion, it's just 1% lidocaine and 1 in 100,000 adrenaline. You can dilute it as you wish, depending on how much volume you need for your operation. And you can add 8.4% sodium bicarb to make it work better and for longer and more quickly. And using it, you can challenge various dogmas. If you don't need a tourniquet, then you don't need a general or a regional anaesthetic. If you don't need a general or a regional anaesthetic, then you don't need an anaesthetist, an operating theatre, a pre-operative assessment for your patient, a recovery ward, admission to hospital, or even a daybed. You don't even need a hospital. So you're converting it into a dental model. For the last 10 years, I've been working to try and show that there's not much difference between infection rates if you operate in an operating theatre or in a treatment room for various hand operations. I've done 2 systematic reviews and a randomized controlled trial of 5 years of practicing of the same procedure in my operating room compared to my treatment room. And I helped write the UK national guidelines. I've also shown in other studies that it's 1/20th of the cost of doing the same procedures in a general anaesthetic in theatre. You require fewer staff, so your lists get cancelled less frequently. And it's less daunting for kids and the elderly who don't like operations in big theatres, but they don't mind a little procedure in a treatment room. So it depends how you badge it. You can bypass theatre waiting lists, and all for a fraction of the carbon footprint. Plus you get better outcomes for your patients. It's less painful. There are no tourniquet time limits, so there's no rushed surgery, and it's better for teaching. You get less bleeding post-operatively, which means you get quicker nerve recovery, less bruising and scarring, and better range of motion. And patients get involved in a surgery which improves their compliance with post-operative hand therapy and leads to less litigation. Plus the biggie is being able to test active motion intraoperatively, so you can find out whether your fracture fixations or tendon repairs fail on the table and do something about it, rather than finding out 2 weeks or 6 weeks later when it's much more difficult. So why do surgeons start doing Wallant? Well, usually not because of any of those benefits I've listed already, but because there's no space in theatres, there's a shortage of anaesthetists, you've got growing waiting lists and nowhere to do patients. Your hand trauma patients keep getting bumped for more major trauma cases, and there are no hospital beds, so everything gets cancelled. And all of this came to light a lot more in COVID-19, when lots of people started doing Wallant for the first time, and many have carried on. But in low and middle income countries that are resource strapped, then this is a daily grind problem, and it's certainly not new for them either. Wallant is an excellent tool when surgical resources are scarce. So what do I do under Wallant? Well, most of my nerve surgery and most of my tendon surgery, including spaghetti wrists and tendon repairs and reconstructions and transfers and tenolysis procedures. Lots of ligament reconstructions, nail bed repairs in kids, and excisions of most tumours. Do most of my Dupuytren surgery and amputations under Wallant. And I've been experimenting, pushing the boat out with what you can do with arthritis surgery, starting small with mucus cysts, denovations, and then moving on to fusions and replacements of knuckles, trapeziectomies, Darrick's excision of ulnar head, four-corner fusions, proximal row carpectomies, and total wrist fusions.
Right, sir, can you move your wrist around for us?
This is a PRC for
Back
Kleinbox's
down.
knees. That's a scaphoid and triquetrum on the table there. And in terms of traumatic wounds, skin grafts and flaps, they can all be done in the emergency department or in your fracture clinic without needing to admit patients. And flaps and grafts are not jeopardized by the adrenaline at all. And surgeons are even doing Wallant replants and revascularizations now. One-stop shop trauma means patients don't need to be admitted. They don't need to go onto any waiting lists, and it's much better for the hospital and for the patients. This is one of my consultant colleagues who took a chop saw to the hand in the middle of COVID when it was virtually impossible to get them into theatre, and fixed his tendons, nerves, arteries, phalanx fractures, and all his wounds, all under Wallant in my fracture clinic. So getting on to fractures, which is what you wanted to hear about, I do all of my phalanx and metacarpal fractures under Wallant, scaphoid percutaneous and open fixations, distal radius platings and K-wirings, both bone forearm fracture platings, clavicle plates, tension band wirings of patellas and olecranons, Lisfranc fractures and foot fractures. I've done some trimalleolar ankle oriffs, and also corrective osteotomies for malunions of hand and wrist fractures. This is a distal radius plating, as you can see. Normally start by not really wanting to watch, but halfway through they realise it's not sore and they want to get involved.
And then that's your broken radius there.
And this just shows how amazing it is to be able to test straight leg raise actively after tension band wiring of the patella, just to show that they can get going on it and it's not going to fall to pieces.
Put it on.
So last year I went to the International Congress on Innovations in Global Surgery in Kenya with Don Lalonde and an international faculty, and we put on a 2-day Wallant workshop with a day of lectures and a day of live operating. We had 42 surgeons come from 10 different African countries who all learned Wallant and then went back to their own countries as Wallant champions to try and spread the word and teach how to do Wallant. But it's certainly not new around Africa. Don Lalonde's been going there for many years, and lots of people have started using it more and more. And even at this conference, I found general surgeons doing hernia repairs, stoma revisions, thyroidectomies and mastectomies using local anesthetic and adrenaline. Obviously, they don't use tourniquets for these anyway, so it's not really Wallant, but it's the same Wallant juice. Similarly, one surgeon did a below knee amputation, and there are lots of eye and ear surgeons, ear, nose and throat who also use local and adrenaline, and they're going to start doing more now they've heard our talks. But one surgeon, she won the prize from my point of view, has done 1,500 cesarean sections under local anesthetic and adrenaline alone, reporting much less blood loss than you do with normal spinal or general anesthesia. So after Kenya, I went down to Malawi, a small country in the southeast of Africa, about the size of the UK with a population of 20 million. And it's the 11th poorest country in the world. It's really resource strapped, and the average monthly wage is just $8 US. Less than 5% of the population have a car, but only 12.5% have any electricity, and they use firewood for virtually all of their activities of daily living. Their medical resources are also pretty strapped. This is their main hospital in the capital city in Lilongwe. And the overcrowding on the wards is fairly immense, with 3 to a bed and people lying on floors and corridors wherever they can, quite often waiting many weeks for their surgery. The theatres are actually good condition, but under-resourced and understaffed, and they're quite often lying fallow because they're not paid enough to work. So I found a treatment room in their emergency department and started doing some Wallant surgery for the patients that I couldn't get into the operating theatre because there were 2 big cases waiting to go in that I didn't want to bump. And because there were a few of us, we sometimes did 3 patients at once, with patients literally queuing around the block for their operations. for one-stop shop surgery. And then patients waiting on a ward for weeks and weeks. Sometimes I would do their operations in the side rooms on the ward because they couldn't get into theatre. And when the theatres were lying fallow in the evenings, I took my team in and we did a lot of Wallant surgery when there's no anaesthetists in the building. So my 13 days of operating in Malawi, all under Wallant in a treatment room, I did a triple tendon transfer for radial nerve palsy, lots of flexor tendons and extensor tendons, 2 spaghetti wrists, loads and loads of wounds, a cross-finger flap, a groin flap, lots of infection cases, incision and drainage, terminalizations and rare amputations, tumours, nerve decompressions, and whatever fractures I could fix without needing any implants or an operating theatre with X-ray. And then foreign bodies. And in theatre, out of hours, also under Wallant, we did a 9-year-old girl's open phalanx fractures, lots of adult finger injuries, distal radius plating, 3 both bone forearm fractures, a proximal row carpectomy for a neglected perilunate, a patella tension band wire, a clavicle plating, and debridement of degloved hands and wrists with skin grafting. Is a machete attack, spaghetti.
Okay. Thank you.
Spaghetti wrist and a plating of the distal radius. So if it wasn't for Wallant surgery, most of these patients wouldn't have had any surgery at all, or we would have had to displace major open fractures and polytrauma from theatre, or they would have had a completely reconstructable limb amputated just to save time and theatre resources, which was suggested at several morning trauma meetings. So in summary, Wallant is safe, efficient, cheap, has a reduced carbon footprint. It's easy, it's fun for the surgeon and the patient. It provides better outcomes. It's suitable for patients not fit for general anaesthetic. It's better for longer procedures, and it's better for teaching. And most of all, it's perfect when surgical and anaesthetic resources are scarce. If you want to learn more about Wallant surgery, then there's Don Lalonde's seminal textbook, which has just published its 2nd edition. Or you can go and visit a Wallant surgeon, as I did in 2014, which got me started. And there's Ali Phillips' Wallant.surgery website, which has now been inherited by the British Hand Society, who are creating a Wallant video library on their website for members. Thanks a lot for listening.
Okay.
Thank you to Nick for a wonderful talk there. It's now time for the question and answer session. I think we have had one question in the chat. I think this relates to Don's talk predominantly. It's from Hadia Negem, and he's asked, how can we avoid infection in cases we keep the dressings in place for 2 weeks? And what if the dressings become soaked?
Yeah, thank you for the question. I think that's a great question. And I think the answer is that we shouldn't keep dressings in place for 2 weeks in most cases. There are some things where you have to for whatever reason, but most surgery, you can take the dressing off and let the patient get in the shower the next day. I do all the time. If I'm doing a flexor tendon and I don't want the patient to get in the shower the next day, we still take the dressing off for our flexor tendons between 3 and 5 days. And I think that one of the biggest problems we have is that a lot of surgeons have this impression that if you sterilize a wound to do an operation and then you leave that bandage on for a week, it's sterile under there. Except for when you take the bandage off, it stinks to high heaven. Sterile stuff doesn't smell. It smells because we're not doing proper wound hygiene. Proper wound hygiene is not just before you operate. Proper wound hygiene is after you operate, take the dressing off and shower the wound. There's this myth that you can't shower fresh wounds. And I think that it's really important for us to dispel that myth. So I think the answer to avoiding infection after surgery, one of the things is take the bandage off and shower the wound, proper hygiene.
Thank you, Don. Just a related question, really. A lot of this does involve patient buy-in and their ability to manage their wound as well at home. I don't know, thinking about my practice in the UK, I think a lot of the patients do disconnect themselves from their own treatment. Have you, in your practice, how do you try and get over that? And have you noticed a difference in when working in low resource settings?
Yeah, that's a great question. And I think that the most important part of that is patient education. And one of the big advantages of Wallant, and almost all of my surgery is with Wallant, is that you actually get to speak to the patient during the surgery. And you can explain to them how important it is for them to get in the shower. And you can show them what their wound looks like at the end of the operation. When somebody's got drug-induced coma and has general anesthesia and wakes up from that and gets a piece of paper that says, take your bandage off and get in the shower, hell, I wouldn't want to do that if I was a patient. I wouldn't know what I was up against. But if the surgeon had walked me through it, explained to me during the surgery how important it is for me to get in the shower, even if it's in a couple of days, and shown me the wound so that I don't panic and go manic after I saw it, because I saw it during the surgery, I find that most patients do very well. And because the patients are awake, when I talk to them, if they're freaking out, then frequently they'll have a family member with them. And I bring that family member into the minor procedure room, because most of our surgery is in minor procedure room, not in the main operating room, just like Nick Jagodzinski just showed. So I'll bring in the family member, either the parent if it's a child, or the wife if the patient is, not remembering everything because he's not totally there. And they will help with proper wound hygiene after the surgery.
Don, do you think there's a role for a skin graft in larger wounds in the forearm or anything, or for anything, would you just go with this this technique you described?
I think there is a role for skin grafts and flaps, especially if the wound is over a joint. Then you're going to get contractures. But even those we can do with Wallant. Almost all of our skin grafts now are done in minor procedure rooms. We have a nitrogen air tank in our minor procedure room. We go, harvest the graft, put on a vac, and send the patient home. So all of that can be done with Wallant as well. There still is a room for flaps and grafts, just not as much as when I started surgery.
And one question for Nick. It says, when operating on the knee, which anatomical areas do you need to inject with Wallant to create adequate anesthesia?
Great question. Sorry, I didn't go into too much technical detail about how to fix fractures in my talk. I mean, fixing the fractures isn't anything different to doing it under any other type of anesthesia. But the anesthetic techniques are pretty much the same for all Wallant operations. First off, you mark your skin incision and you do a subdermal injection all the way down the skin incision. And then when that's numb, you numb the bone. You can miss out everything in between pretty much, but you get down onto periosteum. I use, importantly, a 1.5 inch long, very narrow 27 gauge needle. And you get down onto the periosteum and you do a periosteal ring block of whatever bone you're operating on. So the radius, you go onto the radial side of the radius and you walk your needle off and then numb up dorsally, come back onto the edge and then walk it off volally and go along volally, and then do it maybe in 3 different spots for the distal radius. And then I'd probably do some in the interosseous membrane. So you've got local anesthetic all the way around each bone. For the knee, for the patella, it's dead easy. For the tibia, it's dead easy. The subcutaneous bone. You'd be surprised at how much volume you need though. And you've got to be aware of the safe limits, which are 7 milligrams per kilogram of patient body weight. So for a 70 kilo man, you're allowed about 49, 50 mils. They are very safe limits. And if you need to use more, then it is perfectly safe to do so, but not published and probably shouldn't. So you need to plan your volume limits in advance. So for a patella, you're going to need probably about 70, 80 mils. So rather than using your 1% solution with 1 in 100,000 adrenaline, you just dilute each syringe by 50% with some normal saline. So you get 0.5% lidocaine with 1 in 200,000 adrenaline, and it works just as well. And if you need 200 mils, such as for trimalleolar ankle or something like that, you dilute it again. So you get 0.25% lidocaine with 1 in 400,000 adrenaline. Or you can put a bit more adrenaline in and go for 1 in 200,000 adrenaline, and that works fine too. I haven't tried going any less than 0.25% lidocaine. Also, for longer bony procedures that can be quite painful post-operatively, you can substitute a little bit of lidocaine for some bupivacaine, volume for volume. But it should never be more than a quarter of your total lidocaine volume. Otherwise, it precipitates in the tissues. And actually, I used to do that quite a lot, but it's got a much reduced safety profile, bupivacaine, and lidocaine is much safer to stick with. And you get a good 6-hour block. You can normally do something else for post-operative pain relief, and it tends to work okay.
Great, thanks for that thorough explanation. I think we'll move on to our second half of the webinar now, and I'll introduce Dr. Egemen Ayhan from Turkey. He's going to talk to us about management of tendon injuries.
Okay. Thank you for this invitation. It's a great privilege to be here. And I will talk about flexor tendon injuries, how to maximize success. During my talk, I will focus on zone 2 flexor tendon injuries. And we have two problems here. First one is adhesions, and rarely nowadays, it's rupture. But how to maximize success in these injuries? There are two fundamentals. First, we have to perform an ideal surgical repair. And second, we have to manage the postoperative therapy period. So what's ideal surgical repair? First of all, for an ideal surgical repair, the timing is very important. You cannot do it when you are tired, an ideal surgical repair. Maybe if you don't have enough teammates and colleagues. So to perform an ideal surgical repair, do not do it in the midnight when you are tired, but as soon as possible, maybe next day or in a few days, in a week, for example, even. Second, meticulous surgery and solid, strong repair of the tendon. And third, to tailor your repair, repairing under Valand is the key to success. What's meticulous surgery? Firstly, the minimal incision is the best, because more incision means more edema means fibrosis, and fibrosis means adhesions. So to make a minimal invasive surgery, firstly, most flexor tendons are cut when the fingers are flexed, semi-flexed, or something like that. So you can think that we always need a distal incision from the injured side. But maybe you can need proximal incision, but maybe it might not be necessary. Incision over A1 pulley, you might need and be ready for that incision, because when the tendons are retracted, you can use this incision. So start with distal incision, then if you need, you can do a proximal incision from the laceration site, and also you might need incision over A1 pulley. Start with a rectangular or Brunner type incision. It's not very important, I think, but if you are lucky, the vincula will hold out to length the flexor tendon. Then that's great. And during the surgery, I like to do it with sharp scalpel dissection, because tearing the tissues is not a good idea. If you have enough experience, then use only blade, use only your scalpel. Here we use the distal incision only and found the distal side of the lacerated tendon. And after that, do not try to go inside with a clamp and try to take out in a retrograde manner and take out the flexor tendon, which was retracted. Instead, I do an A1 incision, just a transverse small incision like trigger finger release, and then push it forward with 2 forceps. And if you do this in this manner, the tendons will follow their anatomy, natural anatomy. They won't turn. Otherwise, if you try to take out from distal side, from inside the pollice, then the tendon might turn, and you will see that maybe you will do a minimal invasive surgery, but it's clear that you might have fibrosis and adhesions. And how to repair? It's not, I don't think that it's very important. You can use any type of suture material or suture technique, but I use 4-strand Adelaide repair, and sometimes add two more strands with modified Kessler. Here, my teammate, Dr. Kadir Çevik, is doing the surgery with Adelaide repair 4-strand crochet. But I think it's again important. Which one? The not grasping the injured tendon ends. If they want to heal the tendon ends, so try to hold the tendon in the uninjured parts like this, and then do the suturing. Epitendinous suture, smoothing, I still use it, but I don't think that again, it's very, very important. I use it, I like it, but the most important, I use it actually for smoothing of the sides. So the most important part is doing a solid, strong repair with slight bulkiness in the repair side and checking it with active movement. Observing if there is any gapping, if there is any catching under the pollice. So doing it with under volant and observing your repair is the most important one after doing a solid repair. And the third one, tailoring of tendon repair. I like tailor my repair always under volant with taking a immediate feedback from the patient. And I like to do adjustments like pulley release and maybe pulley reconstruction sometimes. I like checking the gapping in repair side. And sometimes I can make something different, some innovations or whatever it is. And ask the patient, is it okay? Okay, go on. I will show some examples of it. After this very important article of Dr. Jimbo Tanks and his colleagues, nowadays we know that critical pollice can be cut. But how long? Can you cut all of the pollice? No. It's supposed that we think that we can sometimes 1.5 or 2 centimeters in long fingers. But it's not actually very clear the limits of really venting the pollice. But here, the important thing is you have to check it under volant if you need to vent the pollice. But this doesn't mean that you can vent all the pollice. You can judiciously vent pollice up to 2 centimeters. But the limits are not so clear. In this patient, I did a 4-strand cruciate Adelaide repair. And now checking the repair with active flexion and extension test. And I see that, okay, it's working, but in the repair side, as you see, there's no A4 pulley as well. Gapping. Yes. So let's strengthen it with additional sutures. And again, check it. No gapping. This patient, the same patient, have both 4th and 5th fingers lacerated. And we started to check the Bay area without pulleys. Here in the 4th finger, it was 1.3 centimeters, and in the 5th fingers, it was 2.1 centimeters. After the repair of 5th finger, again, I am checking it if I need a pulley reconstruction. Okay, I decided to go ahead. And yesterday, my resident sent me this video of the patient. Do you see it? Again, I will show it again. Not a bad, yeah, it's good, but maybe some in the 4th finger, very minor amounts of flexor contraction, possibly because I try to strengthen more. Another patient, FDP and FDS tendons laceration in the index finger. Here, we repaired only the radial leg of FDS and FDP repair. This is the radial leg. And do you see the slight bulkiness? This is slight bulkiness. It's around 30% mostly, not more than that. And check it, the bare area. I know that here it might be 20 or 25 because there is also the pulley effect of FDS radial leg. I know it, but again, we checked it. Yes. Okay, not bad. And last week, I contacted the patient. He's living in Ankara, in the capital of Turkey. I'm in Istanbul. And I think it's a satisfactory result. A neglected flexor tendon injury, 10 months. I think it seems that FDS is working, but FDP is not working. And as you can see here, I was ready to do a PL grafting. I administered the local anesthetic to the PL tendon graft areas. And here, I couldn't see any FDP proximal stump of flexor digitorum profundus. I could find it after dissecting everything, and I could find it inside the palm, and it was impossible to push forward after 10 months. FDS was okay, but here we had to decide to treatment. Do we graft it, 1-stage grafting, or 2-stage flexor tendon reconstruction? And will I need more pulleys? How will I do tendon grafting in the 5th finger, which is a small finger? And so I want this patient to be function. But FDP distal stump was there. It was just between FDS tendons. So I thought that maybe we can try to kind of tendon transfer or tenodesis end of the FDP to the FDS repair. So these are the sutures that you can see. After repair, asking to patients, did you like it? Is it okay for you to do like this? And if also patients accept, and also we consult together, and then we go with this kind of innovations maybe. And I do all these surgeries under Valand in a small room nowadays in my new hospital. So this is the room this for extensor tendon re-rupture of patients. So we do simple draping in this room with my nurse. There's enough evidence that field sterility is enough for all of these surgeries, soft tissue surgeries, and also key wiring of fractures as well. And also, I do not administer for soft tissue surgery any antibiotics. And one last few words about therapy. Here, my therapist, now we are not working together, we are in different cities, but Zeynep Tuna, we did all these surgeries, we did manage these patients together. Because if you, sometimes my therapists also join to the surgery, and it creates a good communication with the patients. So sticking to close communication is very important in my opinion, because with Valand, patient education and therapy both starts intraoperatively. I advise to all of my patients to immobilize for any surgery, for tendon surgery and fractures, to elevate his hand, and also we sometimes still use telerehabilitation with my therapists, and early active mobilization is the therapy modality that we prefer. In this article, it's a free article, and you can access to 13 videos and different adjustments, doing polar reconstructions and sometimes polar releases and fractional lengthenings with under Valand. And thank you very much for your patience. And this is my clinic, and I'm happy to host you if you have time to come to Istanbul. Thank you.
Thank you, Egemen, and for a great talk and excellent demonstration videos. I would like to introduce the next talk, which is Folake and Meg. We're going to talk about creative rehabilitation and virtual hand care.
Thank you, Krish. I think Folake is going to make a start for us.
Good morning or afternoon, depending on where you are. I hope you can hear me. I'll be talking on, it's a joint presentation on creative rehabilitation and virtual hand care. We'd like to acknowledge the hand therapists in our centers, Mrs. Sarah Rogers from the hand therapy unit at Sheffield, and Mr. Adeyemi Ayeni from hand therapy unit at National Orthopedic Hospital, Lagos, who also gave us ideas and contributed to this presentation. As a form of introduction, hand rehabilitation is the act of restoring the hand to normal or to near normal after an injury. So yes, so many things had been discussed today concerning hand injuries and care that are being given. However, after every procedure that is being done, there is need for rehabilitation of the hand. And whether it's trauma or reconstruction, thus hand rehabilitation to have good success in whatever care that is given. Hand rehabilitation can be preventive, restorative, supportive, or palliative. And what is creative about hand rehabilitation? Yes, you have different models of care in varied centers over the world. In some centers, patients can come in readily for care, and care is relatively free, while in others, they need to pay fee out of pocket. So we need to think of ways of still making these patients have good rehabilitation after whatever hand care has been given. So it's very important in hand rehabilitation to counsel the patient about the importance of the care post whatever procedure has been done. Either it's conservative management of fractures, surgical repairs, treatment of fractures, so as to make them be on the same page with you. And this will also help with a good outcome as per they understanding the importance of rehabilitation. As said by the last presenter, he commented on the care which is being given with his therapist and the importance of rehabilitation after a hand procedure has been done. And there are various kinds of injuries. Sometimes some patients lose some parts, and you may need to just help them recover maximum function of whatever residual hand defects which they have. And hand function recovery may be from surgeries, from congenital anomalies, or from even immobilizations. So what are the challenges when one is rehabilitating the hand? There are various. You have the patient factor. You need to carry them along and let them understand. You have the factor from the health personnel point of view of having to educate the patient and having to encourage them to get the appropriate care. So what are the challenges of this rehabilitation in low and medium income countries? Like in Nigeria, where I practice, you have over 200 million people, and most patients pay fee out of pocket. So some of the challenges which may occur may include the financial challenges because they need to pay for the services which will be rendered pre-paid services. Economic challenges, that is involving the countries and what facilities have been put in place. Some have challenges with having to travel long distance to get to the facility where they'll get the care, and that may want to put them off or discourage them from actually having the rehabilitation. And having to explain the importance may actually help those patients to cooperate and follow instructions to have a successful outcome after a hand procedure, surgery, or care has been given. Some also have problems with taking off time at work to actually come into the healthcare facility for therapy. So one would, based on all this, will need to think about ways of rehabilitating. And of course, we know rehabilitations can be either by passive range of motions for the hand or by active range of motions of the hand. A passive range of motion being that done by the patient as depicted in the picture below here, which shows that the patient actively moves the finger, or it can be by passive motion. Someone is helping here, or this is self-passive motion in this other picture. So what are the ways of achieving this hand rehabilitation in the various climes? It's very good for I mean, it's very good to have a therapist to work with you, because patients tend to follow instruction when the doctors give instruction to the patient. It may be nice to have a setup where you have a combined clinic with the hand therapist, such that they will be able to understand, the patient will be able to understand and will be able to accept more of what the hand therapist will do to have successful hand outcomes. And it goes without saying that a good relationship with the hand therapist is of essence to have a successful outcome for hand care. So I've mentioned about the emphasis to the patient. So what are the various ways of getting to the patient? We should start considering more of using the social media or using the phones for rehabilitating those patients, especially when they can't get to the hospital or days that they don't need to come to the hospital, the kind of instructions they can follow to help in getting good outcomes. This entails the use of leaflets, the use of videos, and there are some centers that have instruction leaflets for hand surgery. An example is the Hamilton instruction leaflets for hand surgeries, and also the use of videos for the patients. I mean, they can video the kind of instruction given by the therapist, and they try and follow that kind of instruction when they are back at home. So one should look at ways of remotely communicating with the patients if the patient can't get to the hospital by phone calls, the use of WhatsApp calls or video calls, to share short videos or skits with them on how to optimize their hand function. And it's always nice to communicate with clear instructions and also to get feedbacks when all these rehabilitation plans are being made for the patients. So what are some rehabilitative methods that can be used at home for the hand when patients cannot even get home? It may include the use of door handles. This is using the round handle to help improve the hand function. This depends on the hand injury. This is the regular straight handle, how the patient can hook it on and can use that for some form of hand rehabilitation. The use of things around the home include the use of ice cream spatulas or the use of rubber bands, you know, using them for various forms of exercises. They can be put against burglaries and they can be stretched as forms of exercises. One can use the local fabricated Indian club for some of the exercises. Picking of small things, such as using the thumb and each finger to pick small things, such as beans or rice, may also help. Having to tell them about exercising their hands in lukewarm water, which improves the blood supply of the hand. I mean, such that they can achieve more hand motion. The use of melted candle wax, you know, which is soft, molding it or plasticine for hand exercises. And you can see the picture here, using the rubber band, stretching them as forms of exercises, or having to do a gentle fist for about 30 to 60 seconds, finger stretches, claw stretches. I think at this point, Meg will continue the presentation. Thank you.
Thank you, Falake. Just as a little bit further introduction to where I work, Sheffield is a city in the north of England. We've got a catchment population of around 3 million, and quite a proportion of them live some distance away. Quite a lot of our patients work in manual occupations, and they often don't have sick time cover. So although they live in a privileged part of the world, they often have sort of household economic challenges that make it more difficult for them to come for therapy appointments. So our therapists were already getting quite adept at connecting with these patients, and the pandemic then pushed that further, and so they've really honed their skills. As Palaki mentioned, I'm very grateful to my colleague Sarah, who's given me lots of information for this talk. The key factor is to find the thing that will really connect the patient with their therapy. Donald and Nick have already talked about how seeing their hand move during the surgery can be a big help for this. The other things is to work out, are they a paper leaflet person? Are they a digital app person? Are they somebody, say they're older and they're not a digital native, but they have a smartphone and they're used to, say, their younger relatives sending them little videos and things, so they know how to deal with that. So there are specific smartphone or tablet computer applications, and I'm going to talk about two of those. One is the hand therapy app, which has been designed by Chelsea and Westminster Hospitals, which is in London in the United Kingdom. And this is constantly growing. They've got a huge wealth of leaflets on there and various other things, which I'll show you some screenshots in a minute. And then the Orientate app is used for complex regional pain syndrome. And it's a condition that constantly fascinates me, and the treatment for it also I find very interesting because of the connection between the periphery and the central nervous system. Next slide, please, Falake.
Just a minute. It's hanging. Okay, yeah.
Just back one. I think it got a bit excited. So the
Okay.
Chelsea and Westminster app, thank you, Falake.
Yeah.
Chelsea and
Sorry.
Westminster one, no problem. The Chelsea and Westminster app is completely free. There is the option to donate if you want to, but there is no obligation to do so. It works on all the different platforms for smartphones, whether that's Android, Apple, or Windows. It is only available in English, though, unfortunately. And this is what the screens look like. So there's an about this app section, which is just an overall introduction, and it's got a nice little video that goes with it. And there's a menu of various different things, as you can see there on the right. There's a specific patient therapy menu and their exercises. There's a full menu of all the exercises, and on each one the patient can go along and star the ones that they're supposed to be doing, or their therapist can do that in the session. They have a full range of leaflets and a feedback option as well. Next slide, please. So there's an example of one of the information leaflets in the middle. So these are PDF leaflets, and they're the ones that Chelsea and Westminster use routinely for their hand rehabilitation. So there's everything for flexor tendons, extensor tendons, elective conditions as well. So it's worth a look just to find out what they've got and how they go about explaining that to patients. The videos of each exercise are a therapist demonstrating them. So this was one of the points that my colleague Sarah made, was that she actually quite often now uses the patient's phone to video the patient doing the exercise in the way that she is coaching them to do. So at the first appointment, which is face-to-face, then she can get the patient to do the exercise correctly, video it on their phone. The patient usually have her talking in the background. There's no concern about data sharing or confidentiality, because it's the patient on their own phone. And if they share that video with other people, then that's their choice. If the or they could even video it on a relative's phone. So those are the options. Yeah. So the other app is Orientate, which is really helpful when complex regional pain syndrome has been confirmed, or if it's in the early stages for suspected cases. I do quite a I have quite a lot of wrist fractures. I have quite a big wrist trauma service. And some of the patients, when they've had non-operative management and they come out of plaster and they feel very disengaged from their limb. And so they can be directed to this Orientate app, which will help them to reconnect the cortical and peripheral connection. It isn't diagnostic for, sorry, could we just go back one, Falake? It's not diagnostic for CRPS. There can be some problems for dyslexic patients, for example. It basically shows pictures of hands, and the patient has to say whether they're looking at a left hand or a right hand. It scores them, and they can track their progress over time. And it helps to normalize the brain representation. Next slide, thank you. So this is what the pictures on the right show you what screen grabs from the app look like. And they've got all different skin tones, male, female, some with nail varnish, some with not, hands in different positions. So, you know, it's not just normal hands, it's hands that are atypical. And it shows you if you're right or wrong. There is a simpler option, which our team used before the app was available. And that just uses photographs from magazines, which you paste onto cards and use as flashcards. And the patient and their relatives could even make a set of these to use at home if they have somebody to help them. And then it's in the same way, you present a picture and the patient has to say if it's left or right. The patient could even video the therapist doing this test with them on their own phone. Or if there's no phone, as I say, they can just make their own cards maybe. And that will help them to make that connection. So it doesn't have to be high tech to achieve the effect. Next slide, please. So as well as doing the therapy, we also need to evaluate how the patient's getting on with their rehabilitation. That can often be virtual, but it's often useful to have a hybrid arrangement. So the patient in a 3-month recovery period may come once or twice to the clinic to see the hand therapist, and the other appointments are on video. And the development is constantly evolving, and our therapists are using telemedicine much more. So some video consultations, some phone consultations, and because some of our patients were finding the video was quite difficult, the older patients especially, or if the data signal is not very good. Good. Next slide, please, Falake. Yeah. So there was a presentation at the British Association, sorry, for Hand Therapy last year, where they looked at the use of goniometry on screen. And what they found was that if the patient sets themselves up in the same way for each video call, and the same therapist is doing the assessments, you can actually make valid goniometer assessments from range of motion of the fingers on the video screen. So you just put the goniometer on the screen. And that was presented. It was a team from Oxford that had assessed that. Next slide, please. So in conclusion, we hope we've emphasised the need for hand rehabilitation in the essential good hand function outcomes after surgery. It's part of comprehensive care. We can achieve this in lower resource or geographically difficult settings by thinking outside of the conventional ways of achieving therapy. Thank you very much.
Thank you, Megan Falake, for a talk on something that's so relevant to all of our practice and how we can start to move with the times and technology. Now, unfortunately, due to unforeseen circumstances, Professor McGrowther won't be able to join us to give his talk on hand infections. So apologies on behalf of the BSSH team. But we do have some questions though, and we can kick off with an infection-related question, I guess to all the panel really. Solomon has asked, do we need to place patients on antibiotics when they're cleaning their hands with wounds with tap water? I think this is particularly related to Don's talk at the beginning. Would anyone see the need to use antibiotics in these circumstances?
Maybe I can start, seeing it was kind of connected to me. So first of all, I do not use antibiotics for clean wounds or clean infections. That's just a waste of antibiotic. Many people do, particularly in the United States, where in some places they have to give antibiotics to keep lawyers happy, but it's not for patients and it's not to decrease the infection rate. So clean operations in Canada don't get antibiotics, generally speaking. However, if somebody has a dirty wound or has a hand infection, because I do Wallant for hand infection all the time, and if they need antibiotics, you still don't have to start an intravenous. If you take Cefalexin or Keflex by mouth, half an hour later, 90% of it is in your blood. So if you take 1 gram of Keflex, 900 milligrams is in your blood half an hour later. So patients don't need intravenous antibiotics. They can have oral antibiotics. You can take Septra. If you have MRSA, you can take that by mouth. It's effective for most MRSA staph infections. And so that's my approach to antibiotics.
I would just-
Go ahead,
Sorry.
Meg.
I would just echo that. I think there's actually been some good evidence in pediatric literature supporting no use of antibiotics necessary for the vast majority of these injuries. So, just agreeing with Don, unless it's something that's already infected, I'm not giving the patient antibiotics.
Thank you. Well, as we're winding down on our time, I'd like to thank all of our speakers. I think these are some outstanding presentations, and I certainly learned a lot, and I hope everybody else did. I'd like to thank all of our attendees. I think that this was an outstanding webinar, and hopefully the attendees learned as much as I did. So thank you for your willingness to spend some time with us today. And I'll turn it back over to Dr. Jain for some closing remarks.
Thanks. No, thank you to our moderators, Warren and Christian. A wonderful job, and to our world-renowned speakers. I mean, impressive talks. You really demonstrated how to really take care of patients really anywhere in the world. And special thanks to the British Society for Surgery of the Hand and and Dr. Whelan for the collaboration on this webinar. I would like to thank you, the audience, for sharing your morning, afternoon, or evening with us, and invite you to join us for our upcoming American Association for Hand Surgery Hand in Hand series webinar with the American Society of Reconstructive Microsurgery on Tuesday, June 11th, 8 p.m. Eastern Time. Burning bridges and upper extremity reconstruction. What do I do now? Good day and good night.